cycle. And this time I compared the Bhatti scoring system versus other scoring system for DIS. Presentation of this paper to see the accuracy and validity of Bhatti's functional scoring system versus clinical, for example, Ferguson and make a clinical scoring systems, and to know the accuracy. And why I have innovated this system, and I will give little brief on the and background. And there are many scoring systems to evaluate the progressive surgical after the surgery, progressive development of DDH for monitoring and ultimate outcome with minimum duration of 1 year. And there are two systems. One is radiological system, in which you all know basic lines we do, and the grading we do, whether it is tonus grading, height of dislocation, are internationally accepted nowadays IHDI scoring system, which are done pre-operatively and then post-operative evaluation with the severance scale system most commonly used, which indicate the acetabular index, containment, and the CE angle. So this was the system which are used radiologically, and there are clinical multiple systems available. Example, oldest one is the severance classification, Mekes criteria, and Barrett's and the Bailey modification, Puyard, Iowa classification, Perzuan or Howard index of motion like this evaluate with the patient for the range of motion. Then some fixing Trevor classification, and some adult hip score system, which is mostly Harris score system. I will give little brief about the systems, and then this recent innovation, why I introduced the Bhatti scoring system. So here is the Mekes system.
We can't see your slides. If you can share, because Saad was playing the recitation, so that's why your slides were unshared. So if you can share your slides again, we can see the slides as well.
I don't know. Yeah, okay.
Aisha,
जी सर.
Now,
can you hear me? Aisha, जब आप बोल रही हैं मुझे आपकी आवाज आती है, मुझे भट्टी साहब की आवाज नहीं आ रही थी.
ठीक सर. सर थोड़ा सा आपको
आ रही है आवाज सर?
जी.
हेलो, आवाज आ रही?
जी सर, हमें आ रही है आपकी आवाज.
अब बेहतर हुई है, जरा और ऊंची अगर हो जाए तो बेहतर है.
सर आवाज थोड़ी सी स्लो है.
हाँ स्लो है, ऊंची जरा होनी चाहिए.
जी आपकी सर इंट्रोडक्शन. जी अब हमें स्लाइड्स भी नजर आ रही हैं सर.
Is it clear now? Is it
yes,
clear
sir.
now? Hello?
जी सर.
It is more clear?
Yes sir, please continue.
Hello?
yes,
ऐसे आवाज आ रही है मेरी? और स्लाइडें भी नजर आ रही हैं?
जी सर, कंटिन्यू सर.
भट्टी साहब बहुत कम आवाज आ रही है, जरा ऊंची नहीं आ रही. भट्टी साहब की आवाज खासतौर पे कम है, बाकियों की आवाज आती है, आयशा बोलती है समझ आ रही है, लेकिन भट्टी साहब की बहुत कम आवाज आ रही है.
आई डोंट नो, मेरी आवाज तो अच्छी तरह है मेरा ख्याल में. साथ मेरी आवाज आ रही है?
जी जावेद साहब, आप अपने लैपटॉप का वॉल्यूम इंक्रीज कर सकते हैं.
मैंने मैक्सिमम किया. आपकी आवाज मुझे आयशा बिल्कुल क्लियर आ रही है. भट्टी साहब की आवाज मध्यम थोड़ी आ रही है, आपकी आवाज बहुत क्लियर आती है.
चलिए, मे बी नेट सेटल डाउन हो जाएगा तो आवाज से क्लियर हो जाएगी.
जी.
Should I continue from here or यहाँ से शुरू कर दोबारा?
Sure.
जी सर, कंटिन्यू सर.
जी सर.
Objective of Bhatti scoring system for DDH evaluation was published in June 2000, in which I have given the details of Bhatti scoring system in cases of early removal of the cast. This time I have given the comparative assessment of accuracy and validity of Bhatti scoring system versus commonly used Mackay clinical scoring system and Ferguson and Howarth clinical system to evaluate post-operative DDH hip. So to introduce why I started this, innovated this, and was basically, I will give in the background of this study. There are multiple scoring system available for radiological evaluation, which is Tonys grading of height of grading, and the IHDI classification, and others which commonly use the lines which we draw, Perkin H line, see the acetabular index. But post-operatively, we most commonly see the acetabular index, Condonman, and the CE angle. But clinically, there are multiple scoring system available, like Severance clinical score system modified by Gibson, Mackay clinical system modified by Barrett and Beckley, then Chouinard, Iowa system of assessment clinically, Ferguson and Hoover system, Travers John Fixin system, and the adult hip scoring system. These are the most commonly used system by various evaluators. In all these systems, patients are evaluated by lying position and see the range of motion index with additional information. Like Mackay clinical scoring system, they are graded excellent, good, fair, and poor, but the criteria they see the stability of hip joint, pain, limp present or not present, Trendelenburg test, range of motion, only internal rotation. And for these parameters, they have designed excellent, good, fair, and poor, but all these evaluations are done in the lying position on the bed. And that does not indicate significantly, particularly the patient disability when he walks, sit, or the squat in position. Similarly, Ferguson and Howarth system give the indications of the range of 6 range of motion: flexion, abduction, adduction, internal rotation, extension, external rotation. Then this each degree of range of motion is multiplied by some factor. Once the factor give the index of the motion, and this basis of this index or motion and scoring, they are divided excellent, good, fair, and poor. But this does not show the clinical disability of the patient. So it only measures the ROM. In 1997, when I published the article, this system was used. When in 2000 I published another study of the DDH, I used the Mackay scoring system. And here is the some Trevor and John's scoring system. This is a little bit elaborative. It combines the clinical assessment and radiological assessment both. Here it indicates regarding pain, that is a subjective system. And then the range of motion is examined in lying position, the limp present or not present, and the functional assessment. Functional, they describe when the patient describes, कि मुझे क्या हो रहा है, I having the pain, I can do this or that, but it has not given fully detail of this function, what function they evaluate, but slightly limited, severely limited, but nothing about the patient can be able to squat anything. So it indicates around pain, range of motion, function as described by the patient, and the radiological assessment. Then the hip scoring system we commonly use for the assessment of the post-operative hip in the adult. Very detailed combination of, you cannot use this system particularly in post-operative DDH in the age of 1 year, 2 years, and 3 years. So since these scoring system, there was significant limitations by the, there is a huge cumbersome exercises and the mathematical calculations are used in this system, and none of these scoring system are able to evaluate real objective functional limitation of the patient, particularly in the Eastern lifestyle, which is commonly accustomed sitting habits like squat, palthi, and the tashahhud position for the namaz. They do not indicate regarding a patient is mostly these systems are used in the lying position to see the subjective assessment or range of motion. But these does not indicate when patient is moving, patient is sitting, they does not indicate the limitation of the system. With this in mind, in the background, I designed the functional system of Bhatti scoring system. And this system are designed to overcome the limitation of the patient of existing commonly practiced method, that is the Ferguson, Howard, and the Mackay scoring system. My hypothesis in this system was the criteria that the Bhatti scoring system is superior to the Howarth and Mackay clinical assessment for evaluation of difficulties of the patient while anchored on performing the daily accustomed habits. Then I also see other parameters like time consumption, compliance of the patient, accuracy and validity, compatibility to Eastern lifestyle, and the Trendelenburg sign when the patient walks and indicate about the pain. So this was the scoring system which I designed in the 10 years assessment by using from 2004 to 2014. And then a dissertation was given to Dr. Aisha Mughal. Here I have indicated around the sitting habits like squat, palthi, and tashahhud position of namaz. I divided these in 3 types: type 1, type 2, and type 3. In type 1, he is normally able to squat 100%. He can be sitting in the palthi without any problem and do the tashahhud position without any problem. In type 2, he is able to squat with heel raised. Most of the time they squat, but the heel is not touching the ground like squat position people do on the Indian commode, and need little support and also feel a discomfort. But in the Palati, he's able to do the Palati, but his knee is elevated on the operated side more than 45 degrees. And there is a difficulty to sit in tashahhud position, and this mostly indicate around the range of motion. I will explain how the range of motion is taken care. And in type 3, he is not able to squat. He may have some stiffness in the hip joint. He is not able to make palthi, and his knee is raised in palthi position over 45 degrees, and he is unable to sit in the tashahhud position. These 3 types of squat, palthi, tashahhud are then scored. Scored and excellent, good, fair, and the poor. Score, then again, score excellent means all these categories of the squat, palthi, and tashahhud type 1. There is no any problem. He is normal, absolutely normal child. But if any patient having problem in the palati or squat position, and they usually have a normal tashahhud. Therefore, when they have a P2 or squat 2 position, we get a good assessment. Mostly it has been seen at the 1 year, but at 3 years, they go good, and sometimes later they may develop a problem in a squat and reverse from the excellent to the good position. In fair, of the 2 of the element, squat and palati is grade 2 or type 2, but tashahhud is okay. Our tashahhud, all these 3 components are in type 2, but not type 3. But if palthi is type 3, then it is considered is fair. But if he is not able to do any of these components, they all are type 3, then it is scored poor component. This was the earlier published in 2030 in the EC Orthopedics Journal. So I will show you the examples of these examples. This is the girl. She is able to sit normally, touching the heel on the ground. She is able to sit in the Palati position with normal position and able to sit in the tashahhud position. So it is considered an excellent. But if these are the GIF positions of this, how they are normally present without any disturb, no limp, no Trendelenburg sign with the interest. Then example is of the good position. In the good position, you see child is able to sit, but squat 1, and she needs a support because she may have some problem in the hip joint, but after 3 years of the age, 3 years follow-up, they significantly improve from this position, from the good to excellent positions. So this was the tashahhud. She is normally absolutely normal in the tashahhud position. So little problem is Palati 2, squat 1. So I indicated it as at a grading 2, and this is at the 1 year, at 3 years age, and this is at the 5 years age. She significantly improved her posture, and this is the radiological evidences of the bilateral hip surgery. Then again, another position, she is not able to squat normally. Her heel is red, but she can do the Palati. She can sit in the tashahhud, and this is the age 7 years follow-up. Absolutely normal, functionally she is good, and she don't have a Trendelenburg sign. As you see, this is the 3 gifts at the 7 years follow-up, their Trendelenburg sign on the left side, and able to sit and squat normally with the normal radiological evidences. Then there is a fair. In the fair, if you see there is a problem on this squat position, also on the Palati position, but she is able to sit in tashahhud. So two of the elements of the squat and Palati are type 2 and type 1. So it is considered as a fair. But if you go to the poor, here she is not able to squat, she is not able to even do the Palati, but she cannot go even on the floor. So therefore, when all three are type 3, they are considered as a poor scoring system. Here is another example of the poor scoring system, perioperatively, before operation, which was not operated by me, but in India. And she's only the bilateral Wedling gate, we can see it. She was operated and the reduction was in obturator fossa, and she was not able to even sit down. Even she cannot in the Palati position or squat position. She needs a support of the wall, or she walks in the chimpanzee gait. This is absolutely poor scoring system post-operatively. So it's one of the example of poor. But I will show you how this improved. So with this background, I done the comparative study to determine the accuracy and validity of Bhatti scoring system versus on the Mackay and the Ferguson scoring system. And I will give the results of this scoring system. And methods was it was a cross-sectional study. It included DDH without other problems or associated problem, and the study was conducted from 2016 to 17, and the minimum follow-up duration was 1 year. The functional outcome was evaluated on all three: combination of Ferguson, which indicate a range of motion, Mackay criteria, and addition to the Bhatti scoring system. So all these three were compared, and the parameters I compared were the time consumed, patient's compliance, difficulty incurred, which also include the pain and Trendelenburg, functional limitation on the clinical evaluation, and compatibility with the Eastern lifestyle. And this was also evaluated with the statistical analysis. And all the operations were done by myself, and during 61-year study, and operated by a single surgeon, placed by the JPMC and NMI hospital. These were included in exclusion criteria, all pathological except only the idiopathic hips were included, and either sex 18 months to 7 years. And these are the clinical evaluation, which I already told you: the Ferguson, Howard, Mackay criteria, functional assessment. And Mackay's criteria, patient was asked to lie down on the couch, while in Bhatti's functional scoring system, it was a patient was asked, and his parents were asked to make the same sitting habit as indicate the patient how she can do the squat, Palati, or the tashahhud positions. And these were the clinical evaluation outcome. Squat in crouch situation, it is the in dictionary it is like crouch situation. Palati is written as a cross-leg situation, and tashahhud it is written as a kneeling. In each patient is marked as a type 1, 2, and 3 regarding limitation of the patient. Here the evaluation parameters, again already I described. They were recorded by video in both, and the by Mackay and the Howard classification, they were numerical assessments, so recorded in the paper, while in the Bhatti scoring on the paper and video assessment. And video mostly help is anytime you can see the video of this patient in sitting. This was the detailed statistical analysis was done by the CPSP statistical specialist, and then the results I will show you in the next. Total number of cases included in this 1 year were the 48 cases, and the male were 9, and mostly 39-88% were the female. Mean age was from the 3 years plus minus 1 year. Range was from 2 to 7 years, and I have not included in this case more than 7 years age. And the mean duration follow-up was 1.7 years, not less than 1 year duration. It includes 1 year to 4.5 years duration. And the overall scoring shows the Bhatti Howard scoring system. They were the 87% were the excellent, 6 were the good, and nearly similar in the Bhatti scoring system. 89% was the excellent, and 4 were good. The score little bit exceeds in this in the Bhatti scoring system, and I will also indicate how this increases. So these three, and then again details are the 89% were the excellent, 4% were good, 6 were the fair, and 100%. This was 100. And the results in the both system regarding the excellent and goods were same. So Ferguson and Hoover compliance were good in the 81% and compliance were 100% in the Bhatti scoring system. While time consumption was the 6 minutes in the other system, while it was the 2 minutes in the Bhatti scoring system. The difference in time and compliance were good to be statistically significant, and the p-value was 0.05. Accuracy and validity in both scoring system were nearly same. So it indicates the Bhatti scoring system is nearly same as per the accuracy and the validity is compared in the Ferguson and Hoover. So regarding discussion, I would give certain points in the discussion that regarding Bhatti, this Ferguson and Mackay scoring, none of the existing clinical evaluation tools reflects the limitation exhibited by the patient while performing accustomed daily sitting habits of the Liston lifestyle. So this is the example in Ferguson Hoover system where the range of motion index were performed in the lying position, and the position of the patient needs to be, cooperation of patient is 100% needed in Ferguson Hoover, while it do not reflect the functional disability of patient while performing the evaluation, and it is not really needed in another person for the recording of the patient with video recording. So if we see here, these patients are evaluated with the Ferguson and Hoover scoring system by, and parameters used. This is the patient is a little bit pain, so and do not allow here, and in the adduction also as well, and in the movement of the flexion extension, she always cries and the supports her head and do not allow. So this is the sign of the less cooperation in the Ferguson and Hoover system. Criteria limitation is based on the history of by the parents. Only they see the limp and pain as a subjective, and objective evaluation only internal notation. And sometimes they shoot Trendelenburg as well. So patient always are scared of the limb manipulation for Ferguson system, do not reflect real functional disability of the patient while performing evaluation. Video recording needs another person. So it means 3 persons are needed. One, the parent, other the surgeon, or who the evaluate, and third person who record the findings and also the video. While limitation in the Trevor group is subjective assessment of pain, objective assessment in the lying position, and assessment do not reflect the Eastern lifestyle. They do not reflect real functional disability of patient while performing evaluation, and same, it needed a 3-person assessment. In Harris score system, mostly it is designed for adult hip for the pre and post-operative evaluation, and do not reflect real functional disability of the patient while performing evaluation. So in Bhatti scoring system, that demonstrate functional activities limitation exhibited by patient while performing daily accustomed habits in the Eastern community lifestyle. Since the personal physical contact of the interpreter is very minimum, video is recorded when patient exhibits these, patient is asked to sit down in these 3 positions, they exhibit good compliance. So compliance is excellent in Bhatti functional scoring system. It not depict the subject assessment, patient performance, endurance and stability, all these, but to a better extent, an objective assessment of range of motion of the post-operative pain is also assessed. The range of motion is assessed while patient sits in all 3 positions of squat and pull-up. Here are the example. When the patient squat, this squat shows the more than 130 degree of flexion of the hip and knee as well. And it is the comfortable abduction of around the 15 to 30 degree. And mild external rotation also is seen. It signifies comfort and daily accustomed habits for which parents are often worried if their child will be able to sit in a squat, Palati or Tashahhud position. If you see Palati, it indicates favorites. It reflects the range of motion hip flexion in 90 to 100 degree of the knee also as well. And it also shows the abduction of the patient when he sits, abduction 45 degrees, and complete external rotation. If he is not doing external rotation, he will not sit in the Palati position. If he is not able to do abduction or flexion, if he will not be able to do this normal position. So it also represents the performance, duration, and discomfort, if any, this patient have. Then there is a tashahhud position. If you see the kneeling position, hip is flexed again at over the 90 degree. It is also 5 to 6 degree external rotation and comfortable abduction. This, and some children, particularly women, sit in like in this position of tashahhud and this position of tashahhud with the leg not under the buttocks but outside. So this also indicates external rotation and internal rotation of the hip joint and the knee movement as well. So most wanted position in lifestyle, Eastern lifestyle, the patient's parent always are concerned of. This also shows the performance endurance and the discomfort. If the patient has a discomfort, he will not be able to sit in this position. So again, so there is benefits of subjective cum objective assessment with Bhatti functional scoring system that indicate pain, duration, range of motion, limb, trembling bird, disability. So these again scoring system are further scored as excellent to poor scoring, which already given the table. So I should not explain again regarding these table, which is scored the excellent when they're all motion are the all habits are normal. If one of the habit is the 2, then it is poor. All 2 of the position are the 2, or any one position is 3, that is called fair. But when all 3 position squat, Palati, tashahhud are in the 3, they are considered as a poor. So literature review, I would say among above mentioned clinical score, the Mackay have been widely used by myself in 2 papers, and in the 97 and the 2000 amongst results of Bhatti scoring system significantly match with the studies of the Abdullah El Sayed and from the Egypt, and another study from the Saudi. They really show the same results. And in compatibility, I would say the current report, however, relieved 94% excellent and good result on Ferguson-Heather and Mackay criteria. These results are also compatible with the other 5 studies. In our opinion, comparing the results with the Mackay criteria with the Bhatti functional scoring system, it says because of evolution seems to be exaggerated in the other system that reflects performance were passively seen. It means when the patient is asked to lie, you can move her hip to exaggerated position. But when you do the Bhatti scoring system like squat, Palati, and the tashahhud, they reflect the nearly same much indication for duration, pain, and the compliance. The time spent in the Bhatti scoring system was 50%, more than 50% were less as compared to the Haworth, Escalin, and Mackay. Even the compliance was very good compared to other system in the Bhatti scoring system, particularly because here the doctor's fear is not there. So the doctor is not touching the patient, but patient is asked to sit away from your table in 3 positions. So accuracy and validity was nearly similar in the excellent and good scores to the Mackay criteria and Ferguson. That indicates this Bhatti scoring system is same, has the same accuracy and validity as the Mackay and the Ferguson scoring system. These are the examples again. Is excellent here and the good, because one of the position here squat is not good. Then here is again good because she is not able to in one position squat, in all other positions she can do. But here the two system squat and the Palati are in the type 2. Therefore, they are considered as fair. But where she is not able to sit on the ground, not able to make Palati or even the ground, they are called the poor scoring system. These are the examples of the other patient which shows the excellent scoring system. All 3 positions are type 1. Here all 3 positions are good. Here a little bit abduction is less on the Palati position. Therefore, this is considered as a good. Here is another example. The Palati is not able to type 3. Therefore, I consider this scoring system as a fair. And here is the example, perioperative and post-operative exam system of the poor. And this patient, after the re-surgery, the 3rd surgery, and of the done here is the soft tissue interposition arthroplasty with Ruyan and the shelf position of this, and patient is able to walk, she is able to cycle, and this is around 7 months follow-up. This was the poor scoring, this is fair scoring. I hope this scoring system will improve on her as she manage herself over 1 year's study. So here is the summary. Here is the patient is evaluated on the lying position, and here patient himself is in doing the sitting, squatting, and Palati position. Therefore, an evaluation and the validity is nearly similar, but functional assessment and the Eastern lifestyle is much better scoring system as compared to the scores done on the lying position. Otherwise, the induration, the Trendelenburg, pain, all is the subjective symptom, which is all indicated here, but it is not indicated in this position when you do subjective assessment in lying position. So limitation of our study is this all is done by intra-observer bias, because this study has been done myself and by postgraduate. It needs the inter-observation studies to verify the accuracy and validity, and I hope the multiple investigator will do, and then we can come to the inter-observer. So I conclude the Bhatti scoring is less time consuming, it is friendly, good satisfactory compliance is there, results are comparable in the validity and accuracy in the Ferguson system. Parameter the evaluation method is new functional etc. significantly compatible with the Eastern lifestyle, and real-time information gives around the limitation of the patient, and good information of additional parameter of discomfort and pain and the Trendelenburg also seen with the Bhatti functional scoring system. This is the reference list you can see in the details, and I acknowledge to editors of the JPO and the expert for providing this opportunity, and there was a contribution in helping me from the by Umayma, Emal, and the statisticians from the CPSB. And I would say thank you very much. Back to the host for the experts' comments and discussion. Hello.
Thank you, sir.
Yes.
Over to you, Dr.
Very
Aisha.
much, sir, for such an elaborate presentation. Now I will move on to Professor Javed Iqbal.
Assalamu alaikum to everybody.
Ji.
Aisha, can you hear me? Is it okay?
Thank you very much, sir, for your.
आवाज आ रही है आप सबको?
Yes, sir.
Okay, so really
Yes,
it was
sir.
a very
Yes,
nice
sir.
and interesting paper by Professor Rishuddin Bhatti, our old friend. So
bilkul,
what
sir.
I will just summarize a few points, and then I will have a bit of the critical analysis, and at the end I will say a few sentences about the conclusion. So as we know, the aim of surgery in DDH, whatever option we take, either operative or non-operative, the aim is to get stable and painless hip. And then as we do in all of our intervention or surgery, we evaluate our results. So DDH post-surgical results are evaluated on X-ray and on clinical examination. So Professor Anisa Bhatti has told us so many different types, classification, different methods, but most popular in the literature or word over are radiological Severin classification, and clinical is Mackay's classification as Mackay's scoring, whatever you call it. In Severin classification, we see X-ray. We make decision, or we just classify on X-ray. It's excellent if there is normal growth of head, well contained. It is grade 2 if head is well contained, but there is some deformity, slight deformed head or proximal femur. And then we go type 3 when there is subluxation, and type 4 when there is dislocation. So that is radiological. But when we come to the Mackay's criteria, Professor Anis Bhatti already has put slide in front of me so I can see myself. So it is, you can say, stable, painless hip. So there is no significant limitation of movement, and good, stable, painless hip, but there is some limitation of movement, Trendelenburg sign, And when there is some pain, there is more abnormality in the movement, but hip is still stable, it's called fair and then poor. This is what we do in literature, how we assess ourselves. When patient comes to our clinic, and this is my experience too, when they come for their follow-up after surgery, so as we do, first I ask the family, so what is your opinion about the surgery? What do you think? So what the difference has been made to your child? So we have to see, we have to ask the patient, and then we have to do the clinical examination. तो पेरेंट जो सबसे पहले बात करेंगे वो ये कहेंगे, अगर थोड़ी ज्यादा ड्यूरेशन है, शॉर्ट ड्यूरेशन के साथ तो ऑब्वियसली उसके अपने इफेक्ट होते हैं, अभी वो बच्चा चलेगा नहीं, फिर चलेगा, लिम्प करेगा. अगर थोड़ा ज्यादा फॉलो में जाए, द फर्स्ट क्वेश्चन विल बी कि बच्चा बैठ नहीं सकता जी, डॉक्टर साहब बच्चा नहीं बैठ सकता, क्योंकि दीज आर आवर हैबिट्स. सो दिस इज आवर कल्चर. जितना मटेरियल लिखा गया है वो वेस्ट में ज्यादा लिखा जाता है. चलो अगर दूसरा कंट्री में भी लिखा जाता है तो दे फॉलो यूजुअली द वेस्टर्न लिटरेचर, नॉट इन DDH. मुझे याद है कि हम आर्थोग्राइपोसिस में व्हेन आई वाज यूके तो हम अचीव करते थे कि 90 डिग्री ऑफ फ्लेक्शन ऑफ नी. व्हाई? क्योंकि उनका वेस्टर्न स्टाइल है, इवन इन द वॉशिंग फैसिलिटीज आर ऑन ए कमोड और चेयर, सो 90 डिग्री फ्लेक्शन ऑफ नी इज सफिशिएंट फॉर द रूटीन लाइफ. बट इन आवर कंट्री एज वी हैव द ईस्टर्न स्टाइल, जिस पर्टिकुलर चीज पे भट्टी साहब ने फोकस किया इस पेपर पे कि दे हैव टू स्क्वाट, बैठते हैं वॉशिंग फैसिलिटीज के लिए. एंड देन हमारा एक बड़ा कल्चर है, एक मैं इंटरेस्ट से देख रहा था, भट्टी साहब पालथी बोल रहे थे, हम पंजाबी में पलथी बोलते हैं, सो दैट माइट बी डिफरेंट बिटवीन सिंधी एंड पंजाबी.
नहीं, डिक्शनरी में ये इसी तरह लिखा हुआ है पलथी.
अच्छा, ये कौन सी डिक्शनरी है? मैं भी पढ़ूं.
ऑक्सफोर्ड मेरे पेपर में दिया हुआ रेफरेंस.
नहीं, मैं अच्छा, आई नो, लेकिन मेरा जाती इट्स माय पुअर नॉलेज. मैंने पलथी और पालथी पंजाबी और सिंधी लफ्ज समझा, मैंने इंग्लिश ऑक्सफोर्ड में समझा ही नहीं कि ये हो सकता है. इट्स ए क्रॉस लेग. व्हेन इन यूके वी यूज्ड टू कॉल द, कैन यू सिट द क्रॉस लेग, वी कॉल इट क्रॉस लेग. बट पलथी जो इन्होंने कहा है वो पलथी और पालथी, तो मैं अपनी जुबान की बात कर रहा हूँ, या हमारे पंजाबी में कहते हैं चौकड़ी. आयशा को पता होगा, है ना, चौकड़ी कहते हैं, ये पलथी कहते हैं, पालती. बट फॉर देयर वी कॉल क्रॉस लेग. बट आई मीन टू से कि पेशेंट्स की फैमिली का ये कंसर्न होगा. तीसरा, अवर रिलीजन, कि बच्ची बड़ी है, बच्चा बड़ा है, वो बैठ नहीं सकता. सो इन दैट पॉइंट ऑफ व्यू इट इज वेरी गुड स्टडी कि बहुत डायरेक्ट जो फैमिली का कंसर्न है उसको इस क्लासिफिकेशन में एड्रेस किया गया. और दूसरी जो मुझे इस चीज में सबसे ज्यादा चीज अच्छी लगी कि ये वीडियो पे भी हो सकता है. जब भी आता है हम बच्चों को कहते हैं ये करो, कोई बच्चा डरता है, कभी रोता, खास तौर बच्चे छोटे हैं और बड़े भी डरते हैं. सो फ्रॉम दीज पॉइंट्स ऑफ व्यू दीज आर टू वेरी गुड पॉइंट. एक तो इन्होंने उस चीजों को जो प्रॉब्लम फेस करते हैं डायरेक्टली उसको एड्रेस किया इस क्लासिफिकेशन में. एंड नंबर 2, इट कैन बी वीडियो, इवन पेरेंट्स घर से भी ला सकते हैं, ये करें और आप उसको एग्जामिन कर लें. यस
जावेद साहब, सॉरी, एक चीज
जी फरमाइए.
ये जो वीडियोस आई है ना, ये वीडियोस कतर से आई है दिसंबर में. मैंने नहीं निकाली, मैंने उनको कहा पेरेंट्स को कि मुझे भिजवा दो. दिस पेशेंट इज इन कतर.
एग्जैक्टली, यही मैं पॉइंट कर रहा हूँ. पेरेंट्स आपको वीडियो, एग्जैक्टली यही मैं पॉइंट रेज कर रहा हूँ कि पेरेंट घर से ले आएंगे, ना बच्चा रोएगा ना हो, तो आपको एक्यूरेट पता चलेगा. तो ये तो इसके बहुत जो मुझे सबसे 2 स्ट्रॉन्ग पॉइंट लगे हैं और अच्छे लगे हैं इस पेपर के, ये लगे. ठीक है, अब तो ये चीजें आ गई. अब मैं थोड़ा सा इसको फर्दर लेता जाऊंगा कि इसमें 2-3 चीजें भट्टी साहब से करेंगे. भट्टी साहब, इसमें आपने कहा है कि एक्सक्लूजन क्राइटेरिया, आई कैन अंडरस्टैंड कि सेप्टिक हिप को हम नहीं करते, हम आर्थोग्राइपोटिक या ट्रेटोलॉजिकल हिप को जब भी करते हैं तो इसमें इंक्लूड नहीं करते. लेकिन आपने शायद एक्सक्लूड किया हुआ है जो हिप डिसलोकेट हुई हैं. ये डिसलोकेट इस हुई है या पहले से जो डिसलोकेटेड रीडू की है, ये मुझे क्लियर नहीं.
ये लिखा हुआ है सेप्टिक हिप टेराटोजेनिक ट्रीटेड नॉन सर्जिकली रीडिसलोकेटेड हिप्स, पोस्ट सर्जिकल सेप्सिस, पोस्ट सर्जिकल. मैंने एग्जैक्टली ओनली प्राइमरी सर्जरी वाले पेशेंट लिए, ओनली प्राइमरी सर्जरी वाले.
लेकिन ऐसा नहीं हुआ कि इसमें कोई ऐसा केस नहीं है कि जिसकी डिसलोकेशन, नॉट एट ऑल. सब इट मीन कि आपकी कोई डिसलोकेशन नहीं हुई और आपके सारे उस तरह के
प्राइमरी के एक्सेप्ट एक्सरे जो मैंने एग्जांपल दिखाया, वो जो पेशेंट बाहर से ऑपरेट होकर आया था, जिसको बिल जो चल रही है चिंपांजी पोजीशन में, वो भी इस स्टडी में इंक्लूडेड नहीं है. इस स्टडी में बिल्कुल वो अभी के है, वो अभी के केसेस है.
दूसरा मेरा एक और इम्पोर्टेंट चीज है कि हाँ, अक्सर 20% ऑफ केसेस आर बायलैटरल हिप. तो इस पेपर में मैं देखता रहा कि क्योंकि बायलैटरल के सर्टेनली जो क्लिनिकल आउटकम है इट्स नॉट दैट गुड एज कंपेयर टू यूनिलैटरल, तो किसी स्टेज पे ये बायलैटरल को अलग नहीं किया गया या मेंशन नहीं किया गया। एम आई राइट? मैंने पेपर को पढ़ा
ये
पढ़े
सामने नजर आ रहा है, ये एक स्टडी में इंक्लूडेड था बायलैटरल, वो मैंने सेपरेट नहीं किया, उस पे मेरा अभी आर्टिकल आ रहा है, बायलैटरल पे अभी आ रहा है।
हाँ, लेकिन कहने से कि अगर इसको हम बायलैटरल अलग कर लेते तो वो चीजें थोड़ी और वाज़ेह हो जाती हैं कि बायलैटरल
इंशाल्लाह अभी मिल जाएगा, क्योंकि ये
मैं वो पॉइंट वही रेज कर रहा हूँ। और एक और पॉइंट जो है वो मैं ये देख रहा था कि ये 18 months or 2 years से 7 years तक है। What's my, now I'm talking about my experience. जब तो बच्चे होते हैं 2 साल 3 साल के, I'm not worried about their hip. Usually they ultimately come to normal, although I counsel the family कि भाई ये थोड़ी सी बच्चों को एक्टिव रखें, सब चीजें रखें। लेकिन as the child go old, जो हमारे हैं ये 7 years तक स्टडी है, वो काफी एज ज्यादा एज है। वेस्ट में ये बहुत ज्यादा एज समझी जाती है 6-7 years की सर्जरी करना। तो इसमें वैसे अगर मेरे पोस्ट ग्रेजुएट या दूसरे सुन रहे हैं तो उनके लिए मैं beside this paper I'm talking about my experience. What I do if this 2 years old or 3 years old, I'm not that worried, but however I tell the family to keep the child active, remain under my follow-up. अब जो इससे ज्यादा बड़े बच्चे आते हैं, 2 किस्म के आते हैं बच्चे हमारे पास। एक तो क्योंकि हमारे हर फैमिली का एजुकेशन लेवल नहीं होता, some of the parents when they see there is a plate, हमने शॉर्टनिंग की है, डीरोटेशन की है, प्लेट उनको नजर आती है तो वो बड़े डरते रहते हैं, डॉक्टर साहब हमें डर लगता है कुछ ये ना हो जाए वो ना हो जाए। नंबर 1 पेरेंट्स कंसर्न या पेरेंट्स एप्रीहेंशन। सेकंड बच्चे भी बड़े मुख्तलिफ आते हैं, कुछ बच्चे वो इतना डरते हैं वो आप प्लास्टर उतारेंगे वो टांग ही नहीं हिलाएंगे। सो वी हैव टू वॉच दोज चिल्ड्रन एंड कीप अंडर क्लोज फॉलो अप ओवर द पीरियड। ओवर माई एक्सपीरियंस नाउ आई हैव लर्नड दैट जो बच्चे बड़ी हम सर्जरी करते हैं, अगर हमें जरा भी डाउट हो, ताकि हिप स्टिफ ना हो, शुरू से उसकी रेंज ऑफ मूवमेंट अच्छी रहे, ताकि अल्टीमेटली हमें ये प्रॉब्लम फेस ना करना पड़े। I have come across, I have came across 2 or 3 cases, वो मैं किसी मीटिंग में दिखाऊंगा। It's amazing to see कि बच्चा वो टांग हिलाता ही नहीं और इतना उसका pelvic tilt है या pelvic obliquity जो सालों में रिजॉल्व हुई और पेरेंट्स रोजाना वरीड हुए, अल्टीमेटली केम टू नॉर्मल। इसलिए कि बच्चे ने शुरू में वो दूर से आए, रिमोट एरिया से आए, बच्चे ने टांग ही नहीं हिलाई, जिस तरह प्लास्टर उसको ऐसे टिल्ट करके रखा, खींचे रखा, अल्टीमेटली ग्रैब द कॉन्ट्रैक्चर एंड देन जो हमें लिमिटेशन जिसमें हम बटी से बाकी चीजें डिस्कस कर रहे हैं, ये वैसे इस डायरेक्ट पेपर से नहीं है लेकिन मैं एक अपना एक्सपीरियंस बयान कर रहा हूँ। तो ऐसी चीजों को हमें बड़ा अंडर ऑब्जर्वेशन रखना पड़ता है सारी चीजें। तो अगर दूसरे जैसे फर्गसन और हावर्ड की क्लासिफिकेशन ने डिस्कस किया, वो भी सिर्फ मूवमेंट पे है। सिर्फ थोड़ा सा मुझे है कि एक जो नेक्स्ट पेपर भट्टी साहब कह रहे हैं ऐड करें, तो इस पेपर पे हमारा सारा फोकस ज्यादा जो है और वो बहुत अच्छे तरीके से हुआ है अबाउट देयर अवर स्टाइल ऑफ लाइफ, जिसमें स्क्वाटिंग, प्लाथी जो अब मुझे पता चला इंग्लिश वर्ड है, या नीलिंग पोजीशन जो हमारे नमाज के लिए हमें पोस्चर बनाना पड़ता है, उसको फोकस है। लेकिन जब हम क्लिनिकल करते हैं, जैसे मैके की क्लासिफिकेशन है, उसमें पेन, गेट का भी पेरेंट्स का बड़ा कंसर्न होता है। एक तो बैठने का होता है, एक कहते हैं डॉक्टर साहब बच्चा चलता है तो ठीक नहीं चलता, लोग कहते हैं बच्चा हमारा ठीक नहीं चलता, लिम्प करता है, माइट बी टेंडरबर्ग गेट, माइट बी अभी तक थोड़े से कॉन्ट्रैक्चर है, कभी हम ज्यादा शॉर्टनिंग करते हैं उसका इफेक्ट होता है। तो जो मेरी ये होगी कि नेक्स्ट भट्टी साहब की जो टीम है या इनके जो हमें नई यंग जनरेशन है, तो वो इन सब चीजों को अगर कंबाइंड करके बनाएं, जिसमें पेन अच्छा इन द लॉन्ग ड्यूरेशन में आती है, शॉर्ट ड्यूरेशन में हमारी कॉम्प्लिकेशन में अगर शॉर्ट फॉलो में पेन नहीं आएगी, पेन आएगी जब फिर कोई सबलक्स होती है, कोई इशू आते हैं, कोई डिस्प्लास्टिक होती है, तो ज्यादा पेन का आता है। बट when we say clinically, it means pain, the patient symptom, it means gait, and the most important and very relevant जो अभी भट्टी साहब ने जिसको हाईलाइट किया, that is their sitting habits. अगर हम तीनों को कंबाइन करके नेक्स्ट पेपर हमारी जो नेक्स्ट जनरेशन लिखे, तो आई थिंक दैट विल बी वेरी गुड आइडिया। सो कमिंग बैक टू, सो इट वाज अ वेरी गुड पेपर, बहुत अच्छी चीज, बड़ी प्राइमरी जो चीज है जो हमें पेशेंट से डे टू डे फेस करनी पड़ती है, उसका डायरेक्ट एड्रेस किया गया, और इसमें अगर हम बाकी चीजें इनकॉर्पोरेट करें क्लिनिकली, तो ये इट विल फर्दर इम्प्रूव आवर अंडरस्टैंडिंग ऑफ द टॉपिक। अगेन आई कांग्रेचुलेट प्रोफेसर निशु भट्टी and his team for this excellent paper, and all our JPO team who has organized such a good academic activities. And thank you very much for having me on this forum.
Thank you very much, Javed Saab. Excellent. Thank you.
Yes, thank you very much, sir, for your kind comments. And I will just like to add the importance of functional scoring here, because we have many young researchers and postgraduate trainees who are here on the forum or who listen to these presentations. We know that whenever we are discussing the outcome of any procedure or any surgical intervention, we go in terms of functional outcome, which can be patient-based and clinician-based. So this is a clinician-based functional outcome, and we will really like to congratulate Professor Nisuddin Bhatti, because this will go a long way in the literature, and whenever anyone is going to discuss neglected DDH, I believe either in the West or in the East, they need to score Bhatti functional system as well, because this gives a very complete objective analysis of patient's outcome. So again, many congratulations, sir. So we have participants here, and we can, we are open to all kind of questions and comments. They can raise hand and, ask their question. Meanwhile, I'll request Dr. Faz, who's the editor of JPOA.
Thank you, Dr. Aisha. Actually, it is a very good paper, and as you have said, now we expect pediatric orthopedic surgeon to use this scoring system in their post-operative evaluation, so that this score is further rectified by other surgeons as well, so that there is a inter-observer and intra-observer that bias, or you can say shortcoming, that can be then eliminated. And with the positive feedback, this classification will be used by most surgeons, and inshallah it will bring very good citations to JPUA as well. We are extremely thankful to Professor Bhatti, who has contributed this paper to JPUA, which is our own journal. And similarly, we expect from our other senior professors to contribute to this journal, as it is now HEC recognized in the Y category. And inshallah, we are in the process of indexation with other databases. In future, inshallah, we will be able to index it. Moreover, this journal club is actually basically for the training. Consultants can share their experience. It's good for them as well. But it's it's a compulsory component of postgraduate training, that they must master this journal club to learn how to write an article, how to critically analyze an article, and how to share their opinion, their experiences. So it's good for them, and we expect our faculty to motivate their trainees to participate in this journal club. I'm really thankful to Professor Javed Saab, who spare his precious time and gave very nice opinion regarding the article. And I'm thankful to Bhatti Saab, and I expect कि भट्टी साहब जो अपना आर्टिकल है नेक्स्ट, वो भी JPUA को कंट्रीब्यूट करेंगे. थैंक यू सर.
Inshallah. Thank you very much, sir. This is my contacts. You can see on the slides here, YouTube and the Facebook, and all this will be present inshallah.
So over to you, Dr. Aisha. I think Dr. Aisha has an internet connection. So,
Okay,
Dr.
you
Faiz,
conclude.
Dr. Faiz, please
Okay.
repeat the session.
I think Dr. Aisha has lost connections. So if there is no questions from participants, Saad, is there any question from participant in the chat box?
No, sir. I again request if any participant have any question, so they are requested to raise their hands so we can get it. Any comments, any suggestion, any questions regarding this presentation, they can raise hand or type in a chat box or a QA question.
Okay. Once our teacher used to say that if there is no question, either they have understood all the things or they have understood nothing.
I think we have understood everything.
Yes, sir. Of course, sir. You are authority on DDH.
Thank you.
And sir, I would request you as well to please write just a piece of editorial for JPA, your expert opinion. So it will be a guideline for our junior orthopedic surgeon, especially for pediatric surgeon. As you know, you are the pioneer of pediatric orthopedic surgeons, and pediatric orthopedic surgeons, they are following you. So it will be good if you write just a piece of editorial or commentary for JPA. It's my humble request, sir.
Sir, it's my pleasure. It's my pleasure. It's my pleasure, my honor. Please let me know detail. I will definitely do that.
Okay, thank you. So if there is no questions, I think we would end up here. Once again, I'm very thankful to Professor Anisuddin Bhatti sir. Thank you, sir. I'm very thankful to Javed Iqbal sir. Thank you, sir. Inshallah, we will have next session with you. And thank you all, the participant. Allah Hafiz.
Allah
Thank you
Hafiz.
very
Thank
much.
you.
Thank you very
Thank
much.
you, sir.